Good afternoon and welcome to the Primary Care Innovations webinar series. We're so glad you are joining us over the lunch hour here on this Friday. A few announcements before we get started with our presentation this afternoon. First, reminder to save the date for the 4th Annual Primary Care Innovations Conference, which will be here in Gainesville, March 6th, 2020. Also, we have sent out a call for submissions. Hopefully you've seen this. If you haven't, please submit your abstracts at primarycareinnovations.cme.ufl.edu. A few housekeeping items prior to starting our talk this afternoon. Number one, please make sure you've muted your microphone as well as your video. We do record these presentations so that they can be viewed at a later date. And if you have your video on, you will be forever on the webinar series for the Primary Care Innovations website. So please mute your video and microphone. If you have any questions, and we really encourage you to ask questions during the session, we've saved between 10 and 15 minutes at the end of the presentation for questions. So please write those in the chat box and we will pose those to the speakers at the end of their presentation. And finally, if you would like CME credit, please make sure to complete the survey which you will receive from the CME office here at UF after our presentation. Today we have Drs. Camps-Romero, Pedoussaut, Anderson, and Amal Bhullar, who's a 4th-year medical student. They'll be sharing primary behavioral health integration, FIU's Upstream model with social determinants of health. I'm going to pass over the presentation to them and allow them to further introduce themselves. Thank you for sharing with us today.
Okay, welcome. So I'm Dr. Camps-Romero, and I have a team here. Dr. Anderson, Dr. Pedoussaut, and Amal Bhullar, and we have one camera here, so I'm not going to be spinning it and right this moment. I'll allow them to introduce themselves when they come on. So thank you all for coming and viewing us today. So we're going to talk a little bit about the model that we have here at FIU in regards to working upstream in kind of an integrated setting, really focusing on the social determinants of health. Okay, our objectives are to recognize the impacts of social determinants of health on physical and mental health outcomes. We hope to describe an interdisciplinary approach to addressing the social determinants of health, integrated in primary and behavioral health care, and providing some examples of how integrating the social determinants of health offers what we believe is a more holistic collaborative care model. We have no conflicts to report. I'm going to start off here just giving you, taking us through kind of a 30,000-foot view of this idea of social determinants of health and their impact on health. And the way I kind of want to tell this story is by comparing the United States healthcare system with other OECD countries. So these are, I think there's 7 other leading economies in the world. The first graph that I'm showing here basically has, is contrasting health system performance with spending. And the higher up you move on the x-axis, the higher you're performing, and the further to the right that you move on the y-axis is the more spending. So ideally, we would like to be in the top left corner. As you can see, most of the OECD countries on the y-axis in terms of healthcare spending are somewhere around the middle to 3/4 of the way, and then there's one outlier, which is the US. And certainly on the x-axis, which is health performance, we are certainly lower. So the US is really kind of isolated here in being in the absolute wrong part of this graph than we would like to be. And basically, it's just showing that overall, in terms of performance, we're not doing as well as other OECD countries, and we're spending a lot more. Okay, we're looking here now at a little bit different. We're no longer focusing on health expenditure as percentage of GDP, which was the first graph. We're also looking here on social expenditure as percentage of GDP. These are OECD countries again, and the health spending is the light blue, and the social expenditure spending is the darker blue. And again, what you notice here, again, from the first slide, we would gather that, okay, the US should be spending more. And then what's interesting here is to see how little as a proportion of GDP we're spending on social spending. So we're really another outlier here in terms of how much we're spending on social care. So we spend a lot on healthcare, and we spend very little on social care as compared to other countries. And most of these countries on this graph actually spend more on social care than they do as percentage of GDP on healthcare. So lastly, we're going to, well, not lastly, I think there's one more slide after this for this part of the talk. We're going to look at, so Schroeder did this article in the New England Journal of Medicine where he basically looked at mortality data, and he was trying to figure out, you know, why people were dying prematurely. And he came up with this graph, which basically shows the reason. And remember, so the previous points we were making on the previous slides was that the U.S. really puts a lot of its money into healthcare. But according to the Schroeder article, really only 10% of premature deaths could be explained by issues regarding health care. So despite pouring all this money into this bucket, it really only represents about 10% of the reasons why people die prematurely. If you notice some of the larger areas, we have, well, social circumstances is 15%, and we have this huge area here, behavioral patterns, that are 40%. So those two areas, I think, lend themselves very nicely to consideration of social determinants of health and addressing, and provide a much bigger target for reducing premature deaths. Okay, so lastly, we're going to now talk about not only length of life, which we've been talking about, but we're also going to look at quality of life as measured by Robert Woods Johnson. This is her county health rankings. What I want to point out in this slide is at the very bottom left here, you see policies and programs, right? And those are really at a level above most of us clinicians can really manage. We have the health factors, which is kind of blown up here to include 4 separate components: healthy behaviors, clinical care, social and economic factors, and physical environment, which should resemble a little bit of what we talked about in the last slide. And then overall, we have at the top left here health outcomes. Again, health outcomes is determined in this graph by length of life, which we've been talking about, but now we're introducing quality of life. And I guess what I want to point out is even when you add quality of life, and you're not just strictly looking at premature death, you're seeing that clinical care really is still only 20% of the piece in terms of health factors, where health behaviors, social and economic factors, and physical environment are making up the other 80%. So in the United States, so we know that the United States doesn't spend as much on social assistance as other countries, but even if you look within the United States, RAND did a study where they showed a really strong positive relationship between higher social spending and by public transfers and better health. So a lot of times we talk about the U.S. system being unique, and in many ways we are. You know, we don't have universal health care, for example. But even comparing within the states and looking at states who do focus more on social spending, we can see within our own country improvements on health. Okay. So now I'm going to turn it over to Dr. Pedoussaut, but we're going to start here with a brief video about the program.
So hello everyone, I'm Maryse Pedoussaut, and I'm going to introduce you to our beautiful world. To best understand our program is to experience it. So here is a glimpse of one of our household visits, and so let's take that little trip together to this world. Please enjoy. Sorry for the delay.
Hold on one second.
We apologize about that, I'm sorry.
I had a big water bill, and it was helped out. I had a food stamp situation. I had no food.
State of Florida ranks 41st in the country in health outcomes. Out of the 67 counties in our state, we're 61st in health outcomes.
When I was asked to open up a new medical school for the state of Florida, I thought it would be a wonderful opportunity to embed the medical school in the community.
Greater than 120 community organizations participate in the program. We pretty much have a very strong representation across all sectors.
It gives people the opportunity to get these resources near where they live.
I think FIU is on the right course by trying to target some of these things that we think are more upstream. We welcome that opportunity to kind of change the conversation away from patients being non-compliant, not taking their medications, to actually making a household visit and realizing what it is that's actually taking place in that household.
You identify things that, the patient would like to work with and skills that you would like to develop, and between the two of you, you sort of embark on this journey where you're both learning and you're both helping each other.
See you again.
You too. So glad to see you. Good.
I think that this has definitely opened up my eyes to see all aspects of taking care of a patient, not just at the bedside.
For me, it's allowed me to grow in that I look at the patient more holistically.
She had a water issue with her utility bills, so the law clinic started helping her out with that. They actually got an agreement in place with her, which she follows through all the time, and she's doing great with. Another goal that we're trying to meet is Medicare. She's already 65, so she's eligible for it. So I'm working with her to choose a plan that is best for her.
The patient's health is much more determined by the other factors, the access, the economics, the education, the health literacy. When we first met her, she was having her stroke. She didn't have running water. She was wheezing. And in 1 year of work, we addressed pretty much all the important things that you need.
Now they come to clinic and you have the one up on that. You know that there's probably something in their life that is totally unrelated to care that is hindering their ability to get better.
It's one thing to treat someone with a medication because they're depressed, but if the real problem is that they don't have a job, then being able to work with them on that is an ability to actually solve the real problem.
If there's some problem that looks systemic in the communities, we will then prioritize it for policy work.
We saw something like 60% of the households were using ER as their usual source of care beforehand, and it dropped like in half.
Lowell Health Center was specifically designed to provide free primary care services to households without insurance in the neighborhood health program. We provide vaccinations, we do pelvic exams, pap smears, we do blood work.
Works perfect for me because I'm working and I do it between jobs.
We've actually saved the state of Florida money. That is, for every $1 they gave us, we returned $6.
I had high cholesterol and high blood pressure. And thank God, I always say when I go see Dr. Anderson and Lorraine that they saved my life.
1 year, somebody as sick as Miss Davis, in the normal circumstances, would have been admitted several times and have used the emergency room several times.
Works great for me and for my family.
We've seen that with our first and second graduating class, a progressively increasing number of our students that go into primary care specialties. This last year was 60%.
So FIU Wertheim College of Medicine was created in 2007 to help and address all the community healthcare challenge and educate physicians with all the social determinants of health to be socially responsible and also to prepare for the new millennium. Our program is unique because it's a 3-year longitudinal. Our students come from different socio-economic class, different ethnicity, different religion. We are very diverse, and this is one of our strengths. In the first year, the students are going to learn about each community with an anthropological perspective. They understand the stress of being Black, they understand the stress of being undocumented, they understand poverty, they understand unemployment. The second year, they're going to start going to the neighborhood. Of course, we cannot serve all, so we only serve the underserved. And our great outreach team did an extensive community assessment for 2 years. Then we had the first map with original communities that were chosen based on a partnership with our county hospital, which is our safety net hospital, Jackson Memorial. The first 3 areas were Miami Garden, Opa-locka, and Northwest and incorporated Miami-Dade. Then a collaborative of Jewish serving organization requested that we care of households in North Miami that were mostly Holocaust survivors. Additional areas have been added based on a natural spray from the original area or a financial sponsorship for this area. Also, what makes our program unique is that the fact that the students are divided in 4 Panther learning communities. And they have a lot of volunteer opportunity, especially with health fair. They provide valuable, very valuable community service. And research programs linked to the community are easy to build on it. So we have students interested in mindfulness, in nutrition, in stroke development. So the neighborhood help is an early clinical experience in the real world setting to address all the social determinants of health. We have a huge community engagement with more than 160 community-based organizations that refer our underserved household. The outreach team is a foundation for the community work. And we have FIU medical, social work, law, physician assistant, nursing student conducting all the household visits. So it's very interprofessional. The student identify the need and work together with the household on agree upon goal. So they learn to be partner with the household and they learn to be interprofessional and the strength and power of working as a team. So the interventions are huge, as you can see. Of course, the healthcare access with free and low-cost community clinic, the mobile health center where we see patients for free, we do PAP for free, we do lab for free. We have the health education for diet, exercise, chronic disease management and prevention, home safety access, and we have a lot of education resources. The other resources are the community park, the library, the support group, the place of worship. The social work help a lot with job training, benefits assistance, domestic violence, safety issue, food pantries. Legal helps also a lot with housing, medical debt, disability claim, immigration. And last but not least, the mental health with counseling and psychiatry with Dr. Camps-Romero and the collaborative care model that was implemented by Dr. Anderson and Dr. Camps-Romero. So the foundation of our neighborhood help is the outreach team. This is our backbone, and they are the first to interact with and focus on the community. As I say, we have a lot of partnership with more than 160 traditional and non-traditional community-based organizations. We measure the social determinant of health for the household member, and there is this novel technology platform called the Health Risk Profile that was created by Outreach for Outreach. So we saw a need to move toward an integration of the social and the medical data, and Dr. Anderson is going to tell you more about that.
Okay, so thank you so much, Dr. Pedoussaut and Dr. Camps-Romero. Once again, my name is Dr. Fred Anderson. I'm a family physician by training, and I have the privilege of working as the medical director for our department. So as was described in the previous slides, we've really been having an effort across our enterprise to try to integrate the social and medical data that we are seeing. Dr. Camps-Romero, could I move that over?
Yeah, give me 1 second.
Yes, I apologize. I'm having a little trouble just viewing the slide information.
Okay, so in the meantime, I can read off the other slides that I do have available here, and hopefully we'll have the information back up very shortly. So we have been keenly made aware by various powerful public health analyses and so forth of the impact of social determinants on the well-being of our patients. And this has led many, not just us, to strengthen the integration of medical and social services. This has also been recognized as being a prerogative nationwide, as the Institutes of Medicine in 2014 had recommended the collection of measures of social determinants of health in various EHRs. They wanted us to specifically start to capture these psychosocial vital signs. And in so doing so, the thought was that in fomenting efforts at data collection in various EHRs, this would enable better research on the determinants of health and effectiveness of treatments. Many of you on this webinar may be already well aware of the various efforts across the country in terms of different efforts in EMRs to capture this information. The National Association of Community Health Centers has been using the Prepare EMR templates. The American Association of Family Physicians has endorsed their Everyone Project Toolkit. There is a lot of research being done at the University of California in San Francisco's Siren Network, where they actually tabulate and list a lot of the ongoing research about the impact of social determinants interventions on health. And I would encourage any of you who are interested to go and look at this web connection to be able to see their latest resource listing. Next slide, please. Thank you. So much like other organizations, we started off with baby steps and how we would effectively capture social determinants in our existing EHR. We use a General Electric product called Centricity, and there we were taking a very close look at the existing ICD-10 nomenclature to see if we could identify various social determinants there. When we did identify them, many of them were under what they call Z-code categories. We try to make them easier to access for our providers and our students by grouping them into different categories. As is shown on this slide, we categorize them under education or employment or family conflict stressors, different categories, and try to bring them to the forefront to allow them to easily capture this in the EMR problem list. Next slide, please. However, in so doing this effort, we quickly realized that there were significant limitations to the ICD-10 and the social determinant capture there. Many of you may be aware of this, that the ICD-10 is pretty much codified from the back in the early 1990s, and hence some of their terminology may already be outdated by close to 20 years, especially when it comes to certain nuanced social determinants of health. We also had a user limitation that licensed EMR providers could add to the ICD-10 problem list, so that students or nurses or social work students actually were not able to add to the ICD-10 problem list without having the licensed providers sign off on them. As was briefly mentioned by Dr. Pedoussaut, we have a robust outreach team that is constituted of a large team of community health workers who are on the ground speaking with these household members and doing household visits themselves. And they have actually taken the time to create their own health risk profile that I'll go into a little bit more detail on. And we realized that unfortunately some of their efforts did not align neatly with the ICD-10 nomenclature as well. So when we quickly learned that there were some growing pains in having two different data systems, one in our EMR, one with our outreach team that was tracking these social determinants, we actually thought that it would probably be a good idea to bridge those two information systems by creating a registry for care management that is a social determinants of health dashboard that we'll be going into a little bit more information in a few slides. Lastly, in retrospect, we think that the limitations on the information system in the EHR may have not just been a source of frustration, but actually an inspiration for us to innovate and not restrict ourselves to the architecture of one information system. Next slide, please. So briefly, what is the health risk profile that the outreach team employs? This is a complex survey instrument that's using various validated numeric Likert scales to quantify the household self-assessments on 10 domains of social determinants of health. And this is asked at the enrollment when individuals and households get into the program. And then these same questions are asked longitudinally every few months. And we're trying to track their well-being over time with our various interventions. Next slide, please. So how is this health risk profile used? The outreach workers try to see if these individuals can be rated on this Likert scale as the highest risk to lowest risk, where the green would indicate that they're in the lowest risk, perhaps the most resilient. The red would indicate that they're in the highest risk. In so doing, we are trying to identify the individuals who have the highest needs from a social determinant standpoint, and we also seek to actually capture the various linkages or referrals to service providers that these outreach workers are engaged in. Next slide, please. This is a busy slide, but if you don't mind just going over it with me briefly, there are I believe 9 different social determinants of health categories that we are listing here as distinct columns going from left to right, from employment, health, and all the way to housing on the far right. What you're seeing is that for each of these social determinants, we are showing 2 different columns. The column on the left is how that household member was classified at the time of enrollment. The second column on the right for each SDH is 6 months later if there were any differences made in the Likert scale designation for their self-assessment of the social risks. And as you can see, we actually were having a demonstrable improvement in this initial cohort and when the health risk profiles rolled out, where a substantial number of individuals with very high risk for employment or for health were actually lowering from their exposure to high-risk environments and becoming more resilient, going more into the yellow or into the green for those categories. But moving a little bit more to the right, we actually saw that there were some categories such as income and so forth that were not moving so much, at least within the last 6 months. And we are mindful that a lot of these health determinants, social determinants, are very intransigent. They're just not something that quickly resolves with one referral. But this is allowing us to actually put in a foundation of quality improvement so we can measure the impact and the vulnerability of our households as we move them towards resiliency. Next slide, please. At this time, let me hand it back over to Dr. Camps-Romero.
Okay, great. So I am the psychiatrist on the team and the director of the behavioral health for the program. I just did want to correct something that Dr. Anderson had said. Our tool is not yet validated, the health risk profile. I was actually on a phone call with the Siren Network yesterday, and they're a big network who works a lot with the prepared template, for example, and getting the social determinants of health out and sponsoring grants. And one thing that was interesting in that conversation is even the validated tools apparently don't have a lot of data behind them. We are looking to validate our tools, and the questions are fairly similar, but I just wanted to clear up that it is yet to be validated. Okay, so I'm going to really talk to you very quickly on the collaborative care model. If we consider the umbrella of integrated models, collaborative care is one of them, and what makes the collaborative care model up are these few central tenets here. It's certainly a patient-centered team care, population-based care, and by that we mean every patient is tracked in the collaborative care model on a registry, and the registry records quantifiable data and allows us to do the next thing, which is this measurement-based treatment to target. Now, the collaborative care model was originally developed primarily for anxiety and depression, and it allows us to use evidence-based care and get to accountable care, where we're less interested in counting widgets or how many of these or of those we did, and really focusing on improvement. So that's kind of the basis of the model itself. The collaborative care model looks kind of like this. So in the middle of this kind of triangle, we have the medical provider at the top, and below him the patient. And these solid connecting lines are frequent contact. So you have the patient coming into his primary care provider, and they're being seen. If there's an issue that's acute, they might be seen more often. So that's a kind of an established traditional primary care setting. What the collaborative care model does is offer some support. And if we move to the bottom left of the screen here, we see a behavioral health care manager. In our program, we use social workers or therapists. Other models use nurses. So this is a new introduction, and you can see that now there's solid lines connecting the medical provider and the patient to the behavioral health care manager. So now the behavioral health care manager is using the registry, which you'll notice at the bottom, to track every patient. So the medical provider might consider, hey, I've got this patient who has a particularly difficult depression. I've tried him on a couple of medications, and I could use some support. And that's where they would call in the collaborative care, enroll this patient in the collaborative care model, and bring on these supports. So now they have a care manager checking in with the patient, rounding with the medical provider, and now tracking these patients on a population health registry. And on the bottom right, you see a psychiatric consultant who's going over in our program, and most programs usually weekly, looking at the registry, looking at all the patients, seeing how they're doing, identifying patients who are not improving. This is the measurement-based treatment to target. Depression scores are not getting better. And they'll have these discussions with the care manager, and the care manager will be rounding with the medical provider, or you can see the kind of infrequent lines of contact. Sometimes the psychiatric consultant, the medical provider will either have informal discussions, or if their patient's really ill, can have a request a direct consult. And then sometimes those patients will end up being followed by the psychiatric consultant because they are perhaps too severe for a busy primary care doctor to devote their time with effectively with. So that's kind of the architecture of the model. We had to tweak ours a little bit because ours is kind of a household-based program. So we have these mobile clinics that are driving into neighborhoods, and we're doing household-based care. And our population is kind of below the safety net. I mean, one of the criteria really is that you have to be uninsured to be in our model. So we had to do things a little bit differently. Traditionally, psychotherapy has been very brief interventions, 2 to 3, problem-focused kind of therapies. Ours, we invest the time in a complete biopsychosocial because we have found that in these communities there's a lot of stress and trauma, and they have come with quite a lot of psychiatric sequelae. We do a full biopsychosocial. We have real therapy that could go on weekly for some period of time, depending on the patient, and of course we do household visits as well. So this is kind of a template of how the model works, and it kind of encapsulates a lot of the criteria of what a collaborative care model is. So this is something that we developed to kind of guide the primary care physicians. And so the first initiative we start, and most of the first initiatives with the collaborative care model, is depression. So we basically use a validated screening tool. In this case, it's a PHQ-9 questionnaire. Generally, the patients might get a shorter version of this questionnaire, a PHQ-2, so this is 2 questions. And if they screen positive, they'll move on to maybe the 9 question. So what we're showing here is some guidance for the primary care physicians on our 9-question scale, the PHQ-9 that we're using, and it's stepped care, basically. So if the patient's doing fine, they're not going to refer to our program. If the patient's mild, PHQ-9 score 5 to 9, the primary care provider may well decide to manage this on his own. As we get into the kind of moderate to more moderately severe range, we have corresponding increasing levels of care, which basically increases the amount of service. So anything, 1 could be simple care management. In our model, step of 2 could be weekly psychotherapy, and a level of 3 is you're being seen at this point by the psychiatrist. And for our program, since we are a mobile health clinic, and there is a level 4 that we feel, well, we really need to link these patients to a primary psychiatric service that can best manage their needs. And this is kind of how we work, and we're constantly gathering data and quantifying how patients are doing over time. So, I mean, the first step in all of this is making sure we're asking about depression. So, we had to universally screen all our patients, and we've done a pretty good job of doing this. Again, our first step is usually the simple 2-question screen. By the time they get in the collaborative care program, we ask exclusively the 9-question screen. But as you can see, we're doing a pretty good job of screening for depression. And then they're in this registry. At first, we had a kind of Excel registry that we were entering by hand, but then we felt that, wow, we really want to get into all the interesting things that we were doing with social determinants of health and the outreach team. And we were able to get a small grant and purchase this Power BI tool, a Microsoft product, that allows us to do some more kind of creative things. And here we'll show you a little bit about how that works. So the program itself is a little bit complicated. In the middle of this slide, you see the household, right? So we use the household in our program as kind of the fundamental unit instead of the individual, because we're really feeling that within the household are this kind of web of relationships that are influencing each other. For example, if the primary breadwinner loses his job, it's going to affect maybe if there's 3 or 4 other people living there as well. So we kind of use that as our central metric. As you see, connected to that on the right is clinical services. So they join neighborhood health, they get access to free medical care if they're uninsured. And then we have the outreach team on the left, and they get referrals perhaps from community partners, or at this point in the program as we've matured, other members will refer other members, and they're getting seen by the outreach team. Now, remember, the outreach services are the ones who are asking our social determinants of health screen that's called the health risk profile. But we have all this data from our clinical services that resides in our electronic medical record. And these are basically two different databases. So what we did with the Power BI tools, we were able to query the electronic medical record, which is a clinical services database. We were able to query the outreach services database, which is the health risk profile. We were able to basically put those together in one interoperable environment, so that now when the collaborative care team is looking at the registry, we're getting data from two different places and considering them together. And what the next slide is, and it's kind of busy, but it's just basically showing one of the different tabs that we have in our registry. So this is an actual registry shot. I guess to focus you is kind of in the middle upper area, you'll see this thing called social determinants, and you'll see several social determinants listed there. So this is a lot of what's being brought in from the outreach. For us, as just a key for us, is if it's capitalized, we know it's coming from one database called the health risk profile. So this is data that the outreach team is capturing. We also capture in those ECOs, as Dr. Anderson was saying, social determinants of health in the electronic medical record. So we try to bring those over. Those are the ones that are in lowercase. And then I don't want to draw too much attention because we're going to use this particular tab screen to talk through some case studies in the future and a little bit in this presentation. But as you can see, we have this PHQ-9 score to the left and towards the bottom, which is our depression screen. And these are different points in time that it's been asked. And then below that, anxiety. And as you can see, we have some other biomarkers and whatever. But we're not going to get too much into the weeds here now. But because we had this ability to query different databases and to graphically visualize them, and other tabs do other kinds of things, we decided, well, maybe we could do a little bit more than just depression. And we were really interested in chronic disease management, as diabetes is the first one on this list here. So we developed a similar system, measurement-based treatment to target. We set guidelines. Okay, maybe somebody who's uncontrolled, hemoglobin A1C equal to or greater than 9. And we did the same thing for diabetes, smoking, obesity. We don't have a set point. We're starting this track now, and I'm thinking BMI of 30, obese or above. But we have so many patients that we might have to raise that a little bit. And we did the same thing for anxiety. And we use a generalized anxiety GAD-7 scale for that. So now because we're collecting all this data, we have the ability to track these patients. So I'm going to hand it back to Dr. Anderson again to talk a little bit more about some of the quality metrics.
All right, thank you so much, Dr. Camps-Romero. So just like most quality improvement efforts, we really look at the data to guide us in what we choose to prioritize. We have actually for many years now been carefully trying to track the chronic disease status for our household members. And for diabetes, we were noticing that we had some room for improvement. In retrospect, we have to kind of look at the fact that the population we're dealing with are very disadvantaged. They are uninsured. They don't have access to a lot of the services that perhaps insured patient populations would. But we do try to compare ourselves with existing HEDIS metrics or NCQA averages. And for diabetes, we looked at the percentage of adults with diabetes who had an A1C of less than 8, one of the HEDIS metrics definitions that they have. And for the NCQA 2016 average for adults with Medicaid, it was 47%. We had been around that at 48% on the right side here in the year 2016 to 17, and we had seen an improvement made from about 5 percentage points in the last fiscal year from 2017 to 2018. And on the bottom part is just a number of people who have poorly controlled diabetes with an A1C of 9 or higher. We were also seeing some significant improvement, but we thought that there was still some chances for opportunities for further intervention. Okay, so what are the various interventions that we have been providing in the collaborative care management program in diabetes? We do have individual and shared medical appointments. We'll be going into more detail about what the diabetes shared medical appointment involves. Of course, as many of you are probably familiar with it, the backbone of these interventions involved education about diet and so forth. Motivational interviewing is a key part. There's also efforts at stress reduction and mindfulness, and really to try to allow individuals who are in these group settings to develop a sense of camaraderie. We have an illustrative case study here for a patient of mine whose initials YL are as is described here. She's a 53-year-old Jamaican female with a history of major depressive disorder with psychotic features who came to see us in May of last year. She had a high PHQ-9 score of 16 at the time, but her presenting complaint to me as a primary care provider was fatigue. that she just was complaining about not sleeping well, all the standard things that maybe a PCP is quite familiar with, and we always have on the differential the possibility that somebody may have type 2 diabetes. And indeed, the finger stick in the office showed that she had a 354 for a finger stick, and the blood work later revealed that her A1C was truly out of control with greater than 19. Her other past medical history included hypertension, osteoarthritis, and sciatica, a Bell's palsy history, which of course goes hand in hand with the diabetes history, as well as pretty advanced and poor dentition. And this patient had actually self-reported not having seen a doctor in many years. Socially, she's a U.S. citizen, but was uninsured. She fell into what we call the Medicaid coverage gap here in Florida, and she did not use tobacco, alcohol, or drugs. At this time, especially because of her behavioral health conditions as well as her out-of-control diabetes, we encouraged her enrollment into the collaborative care program. Next slide, please. This is a snapshot from the outreach standpoint of the health risk profile, how this client was doing. And she was identified as having several social determinants in the orange or the red range or the higher risk, where her income was identified as essentially being maybe basically meeting her needs, but then sliding into the inconsistently meeting her basic needs. She was unemployed, and her health care initially at the point of enrollment, she did not have access to healthcare, but now she was establishing care with us as her PCP. So you were seeing that moving from the red to the orange. Next slide, please. So further on how this client has been doing over the last year or so since enrollment, she was connected with her therapist who did provide dietary counseling, behavioral health interventions. We did start on an SSRI in collaboration with her psychiatrist and myself as a PCP. Her PHQ was, of course, very much followed, and fortunately, we've actually seen it go all the way down to 0, and her psychosis symptoms have fully resolved. Her anxiety remains quite low, and she's now off all her behavioral health medications, and we've been able to get her on 2 diabetes medications with very good control, actually exceeding my expectations for what those 2 medications could do. These medications, of course, there's some cost barriers for some of our patients, so we do take the time to look at GoodRx or discount pharmacy programs. We are actively participating with AmeriCares to connect eligible patients with free medications through them, and we were able to get her several medications such as Flozins and Gliptins through AmeriCares that would otherwise be very expensive. She participated very actively in our diabetes shared medical appointment, and I think because of this disciplinary approach, we've actually seen a very significant improvement in our A1C, going from greater than 14 and then trending downward, and the last one being 7.0 just 2 months ago. And she's also on top of that now fully up to date on our breast, cervical, and colon cancer screenings. Next slide, please. Okay, so let me hand it at this time to Dr. Pedoussaut. Thank you.
Thank you so much, Dr. Anderson. So the way we organize our shared medical appointment is first by introducing, welcoming the patient. Usually we have a bottle of water and some apple or some fruit. Then we welcome them and we have them sign a consent. We introduce what is a shared medical appointment and all the team, because it's very interprofessional. And we start with breathing exercise, mindfulness. Then we have a quick mindful eating, just 5 minutes, so it's modified from Dr. Kabat-Zinn. And I had been grateful and smiling. Then we review the lab, and we will have education with our nurse. It's going to be on nutrition and exercise, and the medical student participate. Finish with a yoga share with the medical assistant, and the last part is going to be with our licensed clinical social worker. She will talk about stress management, and we do the motivational interviewing in group. What I've noticed with us motivational interviewing is that when we talk about the importance scale, we get very high number, like 9/10 or 10/10, when we ask them how important it is for you to monitor you and improve your hemoglobin A1C, and which is something that I usually don't see when I do a one-to-one motivational interviewing. Usually I get like a 5/10 or 6/10. Then we have a vision board that is the plan of the patient, and we will finish with a confidence scale on their plan. And here again, I get really score very high, like 9/10, when I ask them how confident they're going to be with their plan. 9/10, 10/10, and usually I get 5/10 or 6/10 when I do a one-to-one motivational interview. Then we will end usually with circle, a commitment circle where everybody stand up, hold hand, and we say we commit to our diet, we commit to our exercise, we commit to take our medication, we commit to positive thinking. So let me transfer you now to our wonderful medical student, Amal.
Thank you so much, Dr. Pedoussaut. So this next case is about my own household member, Miss CS. She's enrolled in NHELP in 2014 and has been an active member since. And I've personally worked with her since 2017, so about 2 years going on to 3 now. And to frame her, she's a 69-year-old Hispanic female with a past medical history of long-standing diabetes, hypertension, hypothyroidism, stress incontinence, and GI upset status post-herculosis. So despite her lack of insurance, her healthcare needs have been met through our program via 3 different appointment types. The first one is the individual mobile health clinic visits, where she focuses on her specific healthcare needs, medication management, and screenings. The second is the shared group therapy, just described by Dr. Pedoussaut. And the last one is the household visit, where we're actually able to go into her home and target some of the specific social determinants of health. And some examples of these are decluttering the apartment and increasing the lighting in the apartment to decrease her fall risk. We'll go inside of her kitchen and look at the different food items and create healthy, nutritious recipes with that. And finally, we'll find a space in her apartment and show her YouTube videos on pelvic strengthening exercises for her stress incontinence and much more. And so all 3 of these appointments were valuable and unique in their own way and contributed meaningful and comprehensible values that she feels made an impact on her health. And so this slide just quickly outlines some of the social determinants of health that Ms. CS has. She's uninsured and therefore lacks access to some of the healthcare services. Her husband is the only working person in the family, so there's a single person income for the both of them. She's primarily Spanish speaking and she has a lower educational level. So some of the accomplishments that we were able to achieve with her are dental referral for a therapist for depressive symptoms, social work referral, sent for a safety net hospital and VA services, and a social work referral for her sleep study for her husband. And now I'll hand it back to Dr. Camps-Romero.
Okay, so I'm mindful of the time. So we have one more case here that I'm going to kind of go through quickly because we'd like to engage with you guys and see what questions you might have for us. So briefly, this is Miss R. And we have a partnership with Baptist South Miami Hospital here, who's situated next to an area of Miami that's historically been impoverished. And they found that they were having an issue with emergency department overutilizers. And they they heard about the program, they created a list for us and said, hey, maybe if we utilize these resources, we can do something about this population and take better care of them. So she was initially referred into the NHELP program in 2015 and then came into the collaborative care program in January of 2016. By the time she got to the collaborative care program, she was diagnosed with a major depressive disorder severe with psychotic features. And in fact, her paranoia was so severe that would keep her from leaving her home. So this was the pattern of Miss R. In this little graphic, the little building-looking things are every time she went to the emergency room. And then she was enrolled in the collaborative care program in January. Used the ER 3 more times in the next 3 months, but one time she was hospitalized after the ED visit, so we felt that was not an overutilization, and the other 2 were secondary to acute trauma that she suffered. And then she experienced a gap of 6 months with no more ED visits. So we kind of wanted to learn more about this case and find out, well, why? How were we able to bend the curve here in this case? And kind of this is what we found. So Miss R required a lot of household visits, a lot of interventions basically from the collaborative care program, from the NHELP program at large. We could actually see her apartment from where the mobile was parked, but because of her paranoia, she wouldn't even come to the mobile health clinic. So we had to come to her, and then fortunately in this program we could. So 33 total visits, including 8 therapy visits that were done in the home, BSW students visiting her house 5 times, MSW students who again do psychotherapy. In this case, it was the family instead of the individual children, and on and off again, biological father. Our student team did 6 visits, interdisciplinary visits as well. Outreach team did additional 5. We had there was a weapon in the home, so our program provides safety locks and a gun safety demonstration, and then several referrals to other parts of our program, law, dental, and educational pipeline. So there really was an investment in Miss R. This is again another snapshot of the registry, and we're trying to simplify it here and get you to focus on that highlighted bottom left corner to kind of show the story of Miss R. So you see, she was severely depressed when she came to our program in January. She was started on antipsychotics and antidepressants, and the psychosis improved, but was still reporting significant levels of depression. She would and then after a little bit of period of time, we started to see some improvement, but then there would be some kind of psychosocial stressor or interpersonal issue that would have her bounce right up. And then again, she would seem to improve, and then she was not very resilient to stressors in her life. So if you look at that last spike up, which is occurring, I don't know, somewhere between June-ish or so, and then after that, we see a decrease and a sustained improvement in her depression. And this kind of coincided with the improvement in her not utilizing the emergency department. And what we noticed when we reviewed the case is that the story of Miss R really begins with a break-in that happened to her home. She lived in public housing, and she had 3 children, and she became very depressed and paranoid after that, would push her couch up against the front door, send her children upstairs to go to sleep, and spend the whole night awake staring at that door for fear that somebody else was going to break into her home. Ultimately, what we feel improved and kept her kind of in sustained remission, frankly, from her depression over time, was the fact that sometime around late June and July, through the help of our program, we were able to find her a new place to live out of this neighborhood. And we took that for us, again, we can't prove it, but we felt that being able to remove this social determinant of health, the stress about her household being unsafe and in an unsafe area, the reduction of that stress seemed to make whatever improvements we were getting, as moderate as they might have been with the medications and the therapy and all of these other things, we really felt that just by removing that one social determinant of health really allowed herself to heal and improve over time. And that is borne out by this graph here. So this is just a summary of what I just kind of went over about the course of care with Mrs. R. And then, the good news is by the end of her stay in the collaborative care program, and once somebody's doing really well for 6 months or so, they really don't require the level of care in the collaborative care program. So Miss R, was able to move, had begun doing some regular volunteer work, and was beginning a small kind of eBay type of business. So what we'd like to focus on really in the future is, if you look at this kind of busy slide again, is what's really changed in this slide is the social determinants of health. We really want to focus on this track and have the data be displayed quantitatively over time, like the other graphs that we have on this slide, so that we can really begin to see these correlations between, wow, maybe the physical health got better and then the depression got better. Maybe there was a social determinant improved and then the psychiatric symptoms improve. Now we see that quite often. Now what we're hoping to over the course of time is begin to see improvement in social determinants of health, perhaps impacting chronic disease or any movement of these 3 approaches: behavioral, medical, social, really and how they interact and weave and intermingle with each other. Okay, so kind of went through that case pretty quickly because I want to leave at least 10 minutes or so for questions. And I'm just going to give it to Dr. Anderson just to close us out on the potential here.
Okay, very good. So I won't go over the entire slide, as we'd rather hear from our audience, but we hope that our discussion of our program, as well as the case studies, has perhaps revealed the potential that collaborative care has in interacting and make a difference with social determinants of health. We do think that as data systems mature, we might be able to be better able to risk stratify certain populations by their exposure to high-risk social determinant conditions, such as fooding or housing insecurity. In so doing, we might be able to expand our toolbox of interventions to go beyond standard medical interventions or education to include other team-based care approaches, such as medical legal partnerships. So I'll stop it there. I think the rest of the slide probably just reinforces some of our key points. Lastly, we do think that some of this discussion can have an impact on public policy to invest in the key players who are important to a collaborative care approach or an upstream approach to social determinants of health. We thank you so much for your time, and let me hand it back to Dr. Camps-Romero.
Okay, so we're ready to open this up. If anybody has any questions or anything they'd like to comment on or discuss, we'd be happy to
Thank you all. Yeah, this is Ryan Nall here at UF Health, and I really appreciate your time and effort with this presentation. Really, truly a phenomenal and inspiring program. For those that are participated, feel free to type your question into the chat box, and we will put those up to the team here at FIU. While we're waiting on some questions to come in, the question I had, I know it was mentioned early on about students kind of orienting to the community. I suspect many of the students you have at FIU aren't, from that, from around that area. What is the process like of orienting students so that they're kind of prepared when they go into these communities to help care for these people?
Yeah, great. So, I'm part of the faculty, so I'm biased here. So I'm going to hand it over to a fourth-year medical student and see if she can remember and the orientation you had for the program.
Hi, thank you so much for the question. Yeah, so in the very first year, right from orientation, we are divided into these Panther learning communities. And as Dr. Pedoussaut said, for each community, there is a sector of Miami-Dade County that we are kind of assigned to. So it could be near Hialeah or et cetera like that. And so from the get-go, everyone is very open to the reality of these neighborhoods. And we have a lot of reinforcement from our faculty, from the officers on staff about what to expect. And, going in each household visit, we never feel any sort of unwelcoming. Every student, I think it's safe to say that every student has felt very welcomed in each of these households. So I think just kind of engaging, it's very unique per household what to expect in terms of the neighborhood surrounding us.
And I'll just expand a little bit about what Dr. Pedoussaut was talking about. We're really in the first year of the program, the students are really getting a specific course. So this is part of this now 4-year community engaged physician program where they're learning about the demographics and what's going on in each of these neighborhoods. They're actually going in and finding out some health disparity metrics. They're learning about the history. They're learning, again, that anthropological piece and the cultural anthropology involved in these neighborhoods, because they may, socioeconomic backgrounds could be quite different from what they're used to. So we try to spend a lot of time getting them to kind of understand, what this population maybe has been through historically and some of the burdens that they're carrying.
Yeah, excellent. One of the questions we had that came in was many of us kind of operate out of this more traditional model, kind of an office visit. You all obviously have, leveraged household visits and kind of these collaborative models. If you were to kind of take one component of what you're doing in these visits and collaboration and kind of bring it back to more of the traditional office-based visits that some of us work in, is there one part of this that you think that's been most valuable that you would try to put in place for kind of more the traditional office setting?
Thank you. That's a great question. I don't think I have a very clear answer to that. I can tell you, actually, on the last slide that I had to skim over, there were some deliberations done in the state of New Mexico as they had actually looked at the Medicaid populations who were cared for at FQHCs, and they had identified that social determinants of health were very predominant in that population, and they decided to mandate that any FQHCs or community health centers that accepted Medicaid patients would have to invest in one case worker for a certain number of Medicaid patients. So they made that decision in a traditional ambulatory clinic setting. That might be the best person, either a social worker or a case manager / that kind of role may be crucial, and to have that person be able to then refer to various organizations. I can't tell you exactly who would be the easiest person to identify, but I think that's going to be fleshed out in various studies that are still probably ongoing.
Yeah, and I would suggest, and I know we're running short on time here, that just as we had to prioritize screening for depression universally, at an office-based clinic, there are a lot of social determinant health screens that are used in regular kind of physical plant type buildings. It's just the matter of making sure you're asking them and then having a workflow or a system whereby you can follow up on those concerns. I mean, you probably don't want to be asking about things that you completely can't manage, but every particular geographic area probably has some strengths or weaknesses in response in terms of what kinds of responses are in the community and tracking those. So, you look for what you feel you can make an impact on in the social realm. You can do that with a screen. There's various ones available, many of them free, some of them built already into perhaps the electronic medical records that you're already using, or you could use them on pencil and paper. And then that next step that Dr. Anderson was talking about, well, great, I'm a busy primary care clinician. I've identified, this patient has a couple of social determinants of health, but, I've got, 12 other patients I have to see today. So what is the workflow going to be so that you can follow up and help that patient and resolve those issues?
Yeah, that's wonderful. Last question before we let everyone get on with their day. You all obviously have great leadership buy-in to this approach. If for those of us that are leaving this talk today and want to consider implementing similar structures or strategies, where do we start? Is it collecting the social determinants data and then bringing that to leadership? Is it trying to convince leadership based on the obviously robust data out there already on social determinants? For the person here that may be in a more traditional structure, where would you say to start?
Wow, that's a tough question. Anybody here want to jump at that one? Or
I would just say that this again is part of a nationwide conversation. How do you actually make the appeal to the C-suite, to ultimately the business manager? I think that the case is being developed that if you invest in impacting these social determinants, you can actually have a significant reduction in overutilization and the overall well-being of the population. Various forward-thinking organizations such as Kaiser Permanente on the West Coast and so forth are already investing in this population health approach. So maybe that population health language is something that the C-suite or the leadership may be more open to, and perhaps that would then open the discussion to social determinants as they go hand in hand in our perspective.
Yeah, and then just briefly, there's already areas in this country where they are beginning to reimburse for these kinds of services. They may not be universal, and they may be pilot projects. For example, the collaborative care program now is reimbursable through Medicare. So this is we've kind of morphed the collaborative care model to include social determinants of health. But I think as more and more data gets out there and we begin to understand, we tried to lay out the beginning of this talk that perhaps by spending a little more on the social stuff, we can improve health cheaper than how we're doing now. So building, I think, that body of literature or having a champion, somebody who could maybe pilot a small project and just look within your own patient panel as a small study or something and get some kind of data that might look tempting. They might let you run with it a little bit. But yeah, unfortunately, the reimbursement universally, although it's changing slowly, is it can be a tough sell. We're an academic institution and maybe, some private institutions that are bound by other kind of obligations, maybe a little more difficult. But we do feel that nationally there's even internationally is going.
Obviously, a clear argument to be made for the impact on social determinants and how it overall affects health. And we thank you all for this wonderful presentation, really inspiring, and look forward to hearing more about this in the future. For those of you that have stuck with us on the call here, please submit your abstracts to primarycareinnovations.cme.ufl.edu. We'd love to see you at our conference, March 2020. And thanks again, everyone. Have a nice Friday.
Thank you very much.
Thank you.
Thank you.